For first talk, I am inviting Professor Akshyaya Pradhan, who is Professor, Department of Cardiology, King George Medical University, Lucknow. He will speak on the heart trials from the American College of Cardiology and ESC Congress 2024. Dr. Akshyaya Pradhan.
Thank you, Dr. Alok. Always he puts me in a tight spot because there are 100 trials and I have to present maybe 10 or 12. It's a very difficult job. But these two trials, American College of Cardiology and ESC, are the most awaited trials of the year. Lots of trials, guidelines are presented, and when you attend them, you read them, you know that what's there in for your future aid in cardiology. And they cover the entire spectrum of cardiology. In this year, I think the good thing was that there were a lot of trials on hypertension, perioperative management, and some pharmacotherapy of AS compared to what I presented here in the same podium last year. So we'll touch upon few important trials. There are lots of trials. Many of them I have missed many of them, but at least whatever I thought that could be changing our practice or could be probably novel, I'll try to summarize some of them. So first trial is about an aldose reductase inhibitor. We all remember after we are now aware after SGLT2 inhibitors that diabetes and heart failure are intricately linked. So, and one of the pathophysiology of diabetes remains the aldose reductase pathway, and if you try to inhibit that pathway, then probably you can prevent many of the complications of diabetes. So, previous generation aldose reductase inhibitors were very weak. They were very had a lot of side effects. So, AT001 is a novel and potent aldose reductase inhibitors, and probably we thought that if you use this, the hypothesis was that if you use it in diabetic patients without overt heart failure, then probably it will prevent the development of heart failure. So this was a primarily trial of diabetic patients without overt heart failure, stage B heart failure. And they're almost asymptomatic, and we randomized them to two different doses of the molecule, 1000 milligram and 1500 milligram. It was not a cardiovascular outcome trial; it was primarily a cardiopulmonary exercise testing based trial, and the primary endpoint was again based on cardiopulmonary exercise testing, the peak VO2, which the previous speaker was telling to, and there was secondary endpoints. So predominantly an elderly population, good representation of females, and more of obese population and long-standing diabetes. So if you look at the primary endpoint, there was not significant change in the peak VO2 max at follow-up, that's 15 months. But in the placebo arm, there was a fall in the peak VO2. That means the placebo arm, even though they were asymptomatic, they were doing worse, whereas the medication arm actually didn't have much improvement, but they were at least static. So the difference was not very significant. So if you look at by that method, this is a negative trial. But if you pre-specify those patients who are not taking any SGLT2 inhibitors or GLP-1 receptor agonists, then you got a significant difference change from the baseline. That was an interesting finding from the trial. Again, if you look at the secondary endpoints, the more than 6% decline in peak VO2, again the trial was negative. But again, you should look at the patients who are not taking SGLT2 inhibitors or GLP-1 receptor agonists, the trial was probably, the p-value was significant. Other parameters were not, significant. The drug was well tolerated. So in this phase 2 or phase 3 trial, the primary endpoint was negative, but there was a significant interaction between what drug the patient was taking and the outcome. So more investigation is needed that probably this molecule is not working or it is not working where it is interacting with SGLT2 and GLP receptor agonist. Now on the surface value, it looks like a useless trial. Why should we read it? But I think not every failure, some failures are actually stepstones for success. If you remember that riociguat had failed in HFpEF, but vericiguat was a positive molecule in heart failure. So you don't know what future it does hold. So this is one interesting molecule. Now second interesting molecule was ninrefaxat. Now non-obstructive HCM, these patients have diastolic heart failure, right? Many of them end up in late stage heart failure. The challenge there is the LV hypertrophy leading to myocardial oxygen imbalance. So probably if we tackle the myocardial energetics, then probably you can actually lead to improvement in symptoms. So nintedanib is again a partial fatty oxidase inhibitor similar to what trimetazidine is. And this molecule shifts the metabolism from fatty acid pathway to glucose so that there is efficient utilization of energy, leading to cellular balance at the cellular level. So in this improved HCM study, again 200 mg BD dose was tried and compared to standard of care. Again, this was a phase 2 study, not a cardiovascular outcome study. Rather, it was again a cardiopulmonary exercise based study and Kansas City cardiovascular questionnaire. These were the two primary endpoints. Again, it was a predominantly, you can say, that elderly population. The drug was safe. There were no significant side effects. Importantly, these hemodynamic agents are neutral. These drugs have a neutral effect on blood pressure, heart rate, so you can comfortably use them. Or rather, you can combine it with other agents. And again, overall trial was negative with respect to Kansas City cardiovascular questionnaire. But if you look at the patients who are very sick, like patients who were in NYHA 3 or who had a very low KCCQ questionnaire at base, there was significant positive. Again, if you look at the CPT parameters, the trial was positive and also in the subset of sicker patients it was positive. There was also some improvement in LSIs in these patients. So this is a phase 2 proof of concept study because for hypertrophic cardiomyopathy there are limited options. Only cardiac myosin inhibitors are the new therapeutic options which I discussed last year. This is a new pathway which has opened up for all cases of hypertrophic cardiomyopathy, whether they are obstructive or they are non-obstructive. So probably by metabolic modulation we can help them, and so this phase 2 trial paves the way for a bigger phase 3 trial. Maybe in future we have a positive trial. We all are using SGLT2 inhibitors in across the facets of heart failure, but in post-MI heart failure the data was limited. The previous trial, DAPA-MI trial, was negative, so we were thinking that probably impact AMI or could be a positive trial. So again, post-MI patients are at very high risk of heart failure. So this trial randomized patients of STEMI or NSTEMI within 14 days of the event to empagliflozin versus standard of care, and patients had to were selected when they were at high risk of heart failure. So either your EF was less than 45 or you had signs and symptoms of congestion with some additional risk factors to create a high risk group. And fairly big trial of almost 6,000 patients. Importantly, this was a well-treated cohort. Most of the patients were revascularized, they were getting RAS blockers, they were getting beta blockers, they were getting, although MRI number is less, but antiplatelet statin, they were all standard of care. Again, the primary endpoint was negative, that is the combination of cardiovascular death and heart failure hospitalization was negative. But if you dissect the primary endpoint, the time to first heart failure hospitalization was significantly reduced by 23%. Now we all know that SGLT2 inhibitors across the board reduce the heart failure hospitalization. So probably in this study also, although CV death was, it was neutral on CV death, but HHF was reduced. And not only the first hospitalization, the subsequent hospitalizations were also reduced. And again, total number of adverse heart failure events, initiation of drugs for heart failure therapies were also reduced. More importantly, the drug use was safe. We are worried in that acute coronary syndrome scenario whether adding another agent which can decrease the blood pressure or lead to sodium excretion could worsen the hemodynamics. It's not so. So the take-home message is that although it did not reduce the primary endpoint, but there was significant reduction in hospitalizations for heart failure, and those hospitalizations for heart failure were not benign events. 20% of those patients who were hospitalized for heart failure were died. So probably in this negative trial, you can sense a positive outcome that if you are using this in patients of post-MI, probably you are not reducing cardiovascular death, but hospitalization for heart failure is definitely reduced. Last heart failure trial is the Finrenone trial in heart failure with preserved or mildly reduced EF. That is a fine arts heart failure. Now Finrenone, we knew from the TopCat trial there was something wrong with the conduct of the trial, because in the TopCat trial, spironolactone patients of America did benefit, whereas the rest of the world or the Middle Europe did not benefit. So probably those patients were not taking the drug, a sub-analysis showed, or they were low risk patients. So Finrenone is a new non-steroidal MRA which has equal distribution between heart and kidney. It has a shorter half-life. It's a more selective, devoid of any steroidal side effects. That means no gynecomastia, no hirsutism, none of the sexual side effects. So in this trial, patients of EF more than 40% were randomized to 2 different doses of Finrenone, 10 or 20 as initial starting dose and build up to a dose of 20 to 40. And again, cardiovascular death and heart failure hospitalization, like the previous trial, were the primary endpoints. And it's a fairly elderly population, high risk population. Most of them had a hospitalization within 30 days to 3 months, and ejection fraction, again, many of the patients were less than 50. So the primary outcome event was reduced by almost 16%, that is cardiovascular death and heart failure hospitalization was reduced by 16%, and total heart failure events were again reduced by almost significant value of 18%. Cardiovascular death per se was not affected, similar to what SGLT2 did in the IMPACT-MI. But if you combine cardiovascular death with total heart failure events or first heart failure event, there was significant reduction. So now mid-range EF or HFpEF, the treatment options are limited. SGLT2 was the only therapy which was approved in 2022. Otherwise, there is no approved therapies for heart failure preserved EF. Subsequently, I think step heart failure of semaglutide was second drug probably which has shown benefit, and this is the third drug to show benefit in heart failure with preserved EF. Across the subgroups, there was no interaction, and hyperkalemia was a side effect. Of course, we know that MRAs will cause hyperkalemia and they will cause hypotension. That's nothing new. So in this subgroup of heart failure with mid-range EF or preserved EF, finerenone reduced cardiovascular events, and these are consistent across ejection fraction, and those who were on baseline SGLT2 or not. Hyperkalemia was common, but hypokalemia was less common. So probably guidelines will take this into consideration and come up with further suggestions. And further on, if you combine all the 4 mineralocorticoid trials, RAILS, Emphasis, TopCat and Fine Arts, then you get a significant reduction in cardiovascular death and heart failure hospitalization. Again, significant reduction in hospitalization for heart failure. For cardiovascular death, you can see that in patients with reduced EF, the value is significant, whereas in patients with mid-range or preserved EF, it's not significant, but there is trend towards significance. So the finerenone and its meta-analysis concluded that heart failure in patients of heart failure, MRI should be a significant component. Coming to lipids, there were 2 big trials, the bridge-TIMI trial and the Victor initiated. The bridge-TIMI trial was primarily a trial of patients with elevated triglycerides. Olezarsen is a new antisense oligonucleotide against ApoC3 mRNA. So if you decrease ApoC3 mRNA, then your TG levels will go down. This was the drug to see the efficacy and safety of this molecule in moderate to severe hypertriglyceridemia. There were 2 doses, 50 mg and 80 mg. You have to give this once a month. And over a period of time, baseline characters were not significant. 50% reduction in triglyceride you could achieve by a single injection up to 12 months. So one injection every month, you get 50% reduction in TGs. You also get a reduction in non-HDL, ApoB, remnant cholesterol, ApoC3, HDL goes up, HbA1c goes up. So, and patients who were achieved a normal TG at 6 months was significantly higher in this olezarsen drug compared to placebo. Not much safety side effects. So this is a first study of a oligosense nuclear ASO against ApoC3 mRNA. There are also siRNAs against ApoC3, but at least there was meaningful reduction in triglycerides. Of course, most of the patients were not having severe hypertriglyceridemia, so we will have to wait for a second trial, but this expands the basket of options for treatment of triglycerides. Next study was the inclisiran's first strategy, that is the Victor initiate. Now, many of your patients in clinical practice on statin do not achieve an LDL goal. What do? Do you add more drugs? Or can you use this new molecule called as inclisiran, which is a small interfering RNA against PCSK9, given twice yearly, it reduces LDL by 50%. So should you wait for your patient to exhaust all the 4 or 5 oral drugs and then start inclisiran, or should you start inclisiran first? This was the trial design. Patients who had their LDL not controlled on hydrostatins, either they were given an option of continuing more oral drugs, or you straight away start inclisiran. And you had to see at the end of 330 days how many patients had their LDL controlled. So the primary endpoint was change in LDL from baseline at day 330, almost a year. So again, predominantly elderly population. And you can see that in the inclisiran first strategy, there was 60% reduction in LDL from baseline. Whereas in the usual care, even in this trial, where patients are being followed up regularly, there was only 7% reduction in LDL. And because of increase in dose, many patients did continue statin in the usual care arm, whereas the inclisiran arm, the statin dose could be kept low and there was less statin discontinuation. So instead of being a trial, you can see that in usual care, the use of other statin lowering therapy was very, very low, indicating a physician inertia that physicians are not inclined to control the LDL more aggressively. Whereas in inclisiran, because the patient had to come just once or twice in a year, the LDL was significantly controlled. Again, inclisiran is already proven to be a safe drug, and this molecule also, in this trial also, it was a safe drug. So this inclisiran first strategy does lead to a significant reduction in LDL compared to standard of care. And despite giving physicians an access to LDL lowering and LDL lowering drugs, generally the physician inertia is very, very high. Regarding hypertension, there were two big studies, the Cardia and Quadro. The Cardia trial was again an siRNA against angiotensinogen, the zilebesiran. It is a siRNA against zilebesiran given every 6 monthly or twice yearly. There was the phase 1 Cardia, the phase 2 Cardia trial, where there was significant BP reduction. This was just an add-on trial. That means in patients who are not controlled on drugs, can you add zilebesiran and get meaningful benefits? Yes. There were significant blood pressure reductions when you added zilebesiran over indapamide, amlodipine or olmesartan, and all the primary secondary endpoints were significantly achieved. And even with a single dose, the blood pressure continued to be low till 6 months in all the 3 arms. And without adding any other drug, your blood pressure was controlled in the zilebesiran arm. So again, this is a new option, therapeutic option in patients who are uncontrolled or who are not getting drugs, because this is a single injection given every 6 months. So the compliance of the therapy is very, very good. Quadro was an interesting study showing that if you start with 4 different drugs, so patients who are not controlled on triple therapy, can we start a single pill with 4 drugs? Perindopril, indapamide, amlodipine and beta blocker. So instead of giving 4 drugs, can you give a single pill combining all the 4 drugs in patients who are not controlled on 3 drugs, that is patients with resistant hypertension? Again, the single pill combination of 4 drugs was more efficacious than triple therapy given separately. Both ambulatory blood pressure, both the office blood pressure, the diastolic blood pressure, the systolic blood pressure, and percentage of patients whose BP were controlled were also higher with the quadruple pill therapy. So it's an interesting concept. We had heard about 3 pills. This is a 4 pill concept coming up, and the 4 pill concept is safe. Of course, hypertension episodes were slightly higher in the 4 pill combination because it's difficult to titrate the 4 pill combination, but it opens up a new concept for us. When a patient is not willing to take multiple drugs, there is a 4 pill combination available for you for treatment of hypertension. For pharmacotherapy for MI, there are two trials. Ultimate DAPT trial was nothing but it's a simple trial showing that if after 3 months of DAPT, can we switch to a ticagrelor based SAPT for the next 11 months. This was a part of the iOS ACS trial, and patients after 1 month of treatment with DAPT who were stable, only those patients who were stable were randomized to a ticagrelor based SAPT or a standard DAPT. As expected, bleeding was the primary endpoint, so this trial had to be positive because whenever you give a single antiplatelet, obviously the bleeding was going to be less. But importantly, there was no difference in MACE also. So probably this attests to the safety of a ticagrelor based single antiplatelet therapy after first month of MI. For first month you have to give DAPT. Beyond first month, when the risk comes low, you can probably switch to a ticagrelor based DAPT, which is very safe according to this study. ABIS trial was a beta blocker withdrawal trial because many of us are confused that if the ejection fraction is high, should we give beta blocker post MI? So ABIS gave a hypothesis that if you withdraw beta blocker after MI in patients who have normal ejection fraction or EF more than 40, then there should be no harm. So the randomized 2 arms, beta blocker continuation, beta blocker interruption, and actually the primary endpoint was death, MI, stroke and hospitalization. And if you interrupted beta blocker, then your event rate was higher. Both the primary outcome and the components of secondary outcome both were higher if you withdrew beta blocker. So and the quality of life was worse. Hospitalization rates were higher, blood pressure was higher, and of course the heart rate was higher. So this ABIS trial told us that you cannot interrupt beta blocker routinely in all patients following MI, even if the ejection fraction is more than 40%. This is in contrast to the reduced MI trial, which showed that if you withdraw beta blockers, probably it is safe. So 2 big trials giving us conflicting results. Probably the truth lies somewhere in between. With respect to perioperative management, 2 important trials, how we manage patients. If you continue RAS blockers before surgery, there is no harm. So this was a stop or not stop trial, where patients who were undergoing major surgery, they were randomized to continuation of RAS inhibitor and interruption, and there was no difference. So you can continue RAS inhibitors. SCOF was an important trial because whenever patients come for angioplasty, angiography or pacemaker, we give him overnight fasting. So SCOF trial was designed to tell whether really an overnight fasting of 12 hours of 6 hours for solid or 2 hours for liquid is necessary. In SCOF trial, whether you fasted the patient or you didn't fast the patient, there is no difference. Rather, patients who did not fast had better, quality of better symptom analysis. So the trial tells us that routine fasting for angiography, angioplasty and pacemaker is not required. However, there could be selected patients whom you will want to anesthetize to do a procedure, you might do for fasting. Otherwise, routine fasting is not required. There were two interesting trials. OCEAN-A was a trial of a newer agent called as factor 11A inhibitors. These molecules are important because they differentiate between pathological and physiological thrombosis. Whenever you give anticoagulant, the pathological thrombosis is prevented, but the physiological thrombosis is also prevented, so there is a bleeding. So if you have an injury in your hand, then there will be no bleeding if you are on oral anticoagulant. But factor 10 inhibitor or 11A inhibitors are special agents which only affect the pathological thrombus. And based on the phase 2 trials, the Pacific AF, where the trial was better than oral DOACs, so this trial was designed, the 50 milligram dose was pitted against Epic-7 5 milligram BD. In this trial, there was no benefit of adding this new agent, rather it was produced harm. So currently this drug is probably will be discontinued, but bleeding was definitely lesser. Symptoms of ischemia were higher, but bleeding was definitely lower. And last, the seniorita trial, that is in elderly patients, should we go for an invasive strategy or a medically management strategy? This was a trial in 75 plus patients. They were randomized for invasive treatment and conservative treatment. There was no difference in outcomes whether you manage them invasively or conservatively. There was difference in non-fatal MIs and subsequent revascularization, but there was no improvement in deaths. So this trial says that there is no benefit of aggressively treating elderly patients with end-stem with an invasive arm. There were a lot of trials, some positive, some negative. I tried to summarize some of them. So in heart failure, these ARISE heart failure say that aldose reduction inhibitors could be a future pathway. In impact MI showed that SGLT does reduce heart failure hospitalization. Improve HCM told us a new molecule, that is metabolic modulation, can work for HCM. And Fine Arts gave us a new therapeutic option for HFpEF. Bridge, TIMI and Victorian showed that the two new injectable agents are safe and effective. For hypertension, again, you have a new molecule called zilebesiran and you have 4-drug combination. ABIS trial says that you cannot stop beta blocker in all patients following MI. Ultimate DAPT showed that you can stop a DAPT and start a novel P2 based SAPT after 1 month of ACS in selected patients. SCOF trial told us that you don't need to fast every patient for routine coronary angiography PCI, and you can continue ACE inhibitors before surgery in stop or not patient. Finally, OCEAN-A was a failure trial of factor 9 11A inhibitor, and Sanjay said that in elderly patients you don't need to go aggressive. Thank you.
Thank you, Dr. Akshyaya. Now I request Dr. P.R. Sinha sir, please come on the desk, and Dr. Ashish Jaiswal. As our customary, every year we give Best Research Paper Award published in Heart India. So this year we have selected Professor Akshyaya Pradhan for Best Research Paper Award, and I request Dr. P.R. Sinha sir, on behalf of Heart India family, to give him this award for the best paper and his contribution to Heart India. Once again, I would like to highlight Heart India is a journal started in 2013. Now it is indexed in Scopus. Thank you, Akshay.